Okay, so I'm coming to the meat of the day now, because you've heard about this thing, Perfected, and I want to test you on it, not. Some people say, well, what the hell is this? I had a phone call after I'd done an interview this morning, about 9 o'clock, because it's Norfolk, mobile phone signal's not good, and I got to the station, it went, quick, we need for the news bulletin, what the hell is the name of this project you were talking about? Because we've had all the people phoning in, they want to know what it's called, and so I got back just before the 9 o'clock news hour. And that made me think, I've got to tell people a little bit about this. So I'm going to do it back to front and tell you at the end what the project is. But before we do that, to take you on a journey. Some of the things have been talked about vaguely today, but I've got some data, not necessarily our data, but data from the literature, including the new NAO, National Hospital Audit, an interesting paper in October 2014 that was released. So let's make a start. Now then, that delightful building there will be known to the table on the left there. It's where that orthopaedic surgeon works, and Martin Patel works as well. It's called the Norfolk and Norwich University Hospital. And why that's there is it's the sponsor of the trials. And also why those ambulances are there is we changed slightly the way we delivered this project to go into the emergency department, because we realised a hospital is more than just a ward, isn't it? The hospital's got a canteen, it's got shops, it's got all sorts of things, lifts, maintenance, and there is this lovely thing with the ER. So I've put the ambulances there because that's a very important area. Unfortunately, we couldn't get out into the ambulances when they picked the patients up. That's pushing it too far. So we have spent some time observing A&E. I didn't manage to get down there. I was tempted and just couldn't find the time. But the team had been going to A&E, and in fact, we had to ask one of the team members to stop because she loved it so much, observing the care that people were getting, that we wanted her to move to the ward. So we redeployed her. We've got some good data from that anyway. So who are we on Perfected? Everyone does these slides, and normally there's about 6, and I started counting it up, and it got completely out of control with the number of bodies involved in this organisation or Perfected team. What I highlight 2 here, or 3, this would have been a foreign country if someone had their way, but it's not now. So the international element is we've got University of Indiana from the complex adaptive systems guru, Professor Malaz Bustani. And then in Sweden, we have a lady called a Swedish professor of nursing, in fact 2 of them involved, who have done one of the few decent sort of pseudo hip fracture. They did a mixed study which had cognitive impairment in it. And so they're our advisors. And the rest of the people are doing bits and bobs throughout. And as you can see, it's a pretty big team. So that's us. How we came together? Well, a long time ago in a faraway galaxy, I lived in Kent, and I worked in Kent with someone down the end there. And we put in a bid to research the patient benefit on hip fractures and looking at troponin as a marker of outcome. You may remember this vaguely, to see if it was indicative of whether people with dementia had a poor or good outcome. It didn't get funded, but I stuck with it. And this was around about 2008. And so Perfected evolved when I moved to University of East Anglia in about 2010 and started up. And it was a very long process to get the grant. It feels like 4 years, but it wasn't like that. It was probably about 2 to 3 years. So this has a long history, but I can go back further than that. I was a poor SPR in Oxford in old age psychiatry for my sins. And I worked with someone called Catherine Oppenheimer, who some of you may know. And we ended up with horrendous battles with nice orthopaedic surgeons, professors of orthopaedic surgery in Oxford, who would phone up and say, look, my boy, take this patient with dementia. We don't want them, we can't do anything with them, put them on your wards. And I'd go, no. And the next minute, my consultant would come down and say, I've just been shouted at by that professor of orthopaedics again. We've got to take the patient. And we ended up all these battles. And so I would eventually be sent in to be shouted at on the ward to try and stop the patients coming our way. Because in the mental health wards, we didn't have any physical, our nurses just didn't have any physical devices, equipment, and they were trying to send people over who needed drips, and we couldn't support it, etc., etc. at the time. So I have a strong passion in this area because I worked in it and I felt thoroughly demoralised, like our anaesthetist friend there, going onto these units, seeing these poor patients stuck on wards. This was in about the millennium, in fact, 1999. I remember it well because I was on call actually on Millennium Eve, and we doubled up because everyone thought that there was going to be a crisis in mental health on the Millennium Eve. Luckily there wasn't, but there we go. It's another story. So what I want to go through is relevant research and context, a bit about our programme, and then show you some of our questions, and then perhaps get some questions back from you as well. So to start with the why. Now we've talked about this today, a little bit about the numbers of patients in hospital. We know that 1/4 of beds are occupied by people with dementia, and that still applies. probably think it's under that, and Martin might agree, it's probably more like a third and rising. Comorbidities are a huge problem. Many of you in the audience are experts on this area and raise this, and we ourselves have an interest. It seems to me the D word automatically means that everything else goes in the dustbin and we just concentrate. It's all related to dementia, even if they've had a heart attack or a diabetic crisis. No, it must be dementia, nothing to do with that illness. So we do need to sort that out. And in fact, the NIHR, for a bit of plug, has a call next year on comorbidities and frailty, and I would encourage you all to think about applying. And the NIHR would welcome application in this area, and we ourselves will be looking at that as well, because it recognises the importance of that. Some years ago, there was a National Hospital audit undertaken by the Royal College of Psychiatrists, which James knows a lot about. And I think at that time they found that only 5% of trusts had any dementia awareness training. They repeated the audit, and the contract has recently been re-awarded to the college, which is great to do, more good work. And it had increased, but it was still in 2013 only 40%. And then John Young and colleagues, sorry, a bit of text here, but I found this sort of squirreled away on PubMed the other night with my friend Roy D'Souza. And they did a more in-depth reviews, and they found that more than half had no record of cognitive assessment still. This is up-to-date data, or functional assessment, 3/4, no functional assessments with dementia. Carer documentation was poor, so 39%. And it was interesting that orthopedics and surgical wards seemed to be particularly problematic. And assessments of falls fell well below recommended standards. So basically people were coming in, not properly assessed for falls, sent home, and then bang, they come back in, as we heard earlier today. So this is fairly up-to-date data. So despite all this interest and information, the data collection period was probably a year or two ago. So we've got, hopefully it's improved a bit since then. But it's still, the most recent data we have is still a significant problem. And that, to me, says that there is dementia training underway, but what the hell is it? Is it implemented? Is it tick box? Is it go to a lecture and then forget about it and the trust goes, ping, we do dementia? Where's the evidence that these training schemes have been properly evaluated and developed? And so that's another why, we recognise that there is a problem with training in dementia in hospitals. It's not, on the surface it's being done, but in reality, I don't think it is, to be honest. And we'll show you we'll briefly discuss some data that we've got on that later on. We know there's the old bed day dropping. This is old data, I think still applies. If you could drop the length of admission by 7 days, you could save the NHS 80 million. That was 5 years ago. I'd double that now. I'd probably save them £160 million a year because of the burden and the numbers and the costs of care rising. So it's a significant cost, this particular group. So we now move on to research into dementia in hospitals. Now, how many studies are there in dementia in acute hospitals reported in the whole world? How many randomized controlled trials? A bit cruel. I'll give you a bit of help. Here's a clue. If you want more, I can roll it down. So in hip fracture, since 2000, there were 72 trials. Cognitive impairment was seldom recorded, and only 1% were even the focus, but it gets worse. Validated screening tools rarely used in all the data. They're using tools that are not fit for purpose in this particular patient group on wards. Our own work. And only 2 trials, I think they're from Sweden, that's actually ever evaluated interventions specifically targeting cognitive impairment in acute hospitals. That's medical or hip fracture or something like that. So there's very little evidence to go on. So when you do your evidence-based trawl to say what's best practice, it's back to what my anaesthetist friend at the back there said, no one's looked at it. And we ourselves had an idea about looking at regional anaesthesia versus general anaesthesia, and it was so complicated. This was 6 years ago. We abandoned it because we got overloaded with arguments about whether to use what type of regional anaesthetic, what type of general. And it's very hard to do these trials. And I think Alan House's group actually with Leeds did one, and it was the Swedes who did it as well. And Alan House's was a BMJ, and that was in the 1990s. So it's quite shocking there's been such a gap. So there I was doing my stuff in Oxford, being shouted at all the paediatric surgeons. The trials were done, and I thought, great, in 10 years' time, I'll come in, be qualified, and it'll all be fixed. And it wasn't. And then I became an academic and thought, well, I'm going to get off stand up and try and do something about it. Oh, that seems to have slipped a bit, doesn't it? Let's bring these down a bit. Okay. So just to put it in context, we know the NHS has severe funding constraints. We heard about it this morning. we believe that service redesign can save money and improve quality. That's what Charles, I think, was intimating. And we talk about the flow of cares. If you prefer. I like, I like the word complex adaptive systems and butterfly effects. And, I read the books. And 5 years ago, I read this enormous book and I got very confused about when a butterfly in South America caused a hurricane. So I've tried to simplify complex adaptive systems into the flow of care. Because it's relevant, but I think that's what underpins the work that we are trying to do. So we're moving towards what the project is very slowly. The problem NHS decision makers have is that they often hear about initiatives like we mentioned Perfected to our AHSN, and they said, all right, we want to buy it. Yeah, we'll commission it, yeah, we'll do it, let's do it. And I said, no, you can't, because we need to do a trial. And they said, oh, well, fine, okay, well, that's normally how it works. We just go ahead and someone comes up with a good idea and we just think it's good. And these trials and things, well, yes, they take a long time to do, they cost a lot of money, we just need to implement and get on with it. So it's the old cart pulling the horse backwards, which is what caused problems for me with Jeremy Hunt last year with the screening and diagnosis, when I accused him of trying to implement a mass screening campaign in dementia, when in fact what I was trying to say was I wanted timely diagnosis, and I did win that argument, and he changed his track too fast. Timely, speedy diagnosis is the important thing. So I think that's a problem that decision makers face. There's a lot of demand. They sit on limited amounts of funds. There's a need. I regularly talk to my commissioner. I feel so sorry for him because he has all these decisions to make in a limited cake. And the cake, as we've heard today, Charles said, has been eaten. So there's not much to do with this. So they've got this. They really don't know what to do. So that's kind of another sort of context thing we're thinking about. We can't just create this monster called Perfected and say, there you go. There's the book. Do it. And we've worked it out, it'll cost you £50 billion and bye-bye. It works really well. So we've got to try and overlay it or enmesh it, or as Steve Eilish says, shoehorn it into the existing system, or try and nudge people to innovate, so break out of their area or their way of thinking, perhaps. A little bit about what enhanced recovery pathways are. They have various names, including rapid recovery programs, but they go back to Denmark. And in fact, I met one of the Danish originators' colleagues. I happened to be at a meeting in America, and I was talking about enhanced recovery pathways and presented as poster. And she came up to me and said, I did the first trial of this with the inventor of it, and I'm glad you're still going, because it's 30 years later, isn't it? And it's still, we never got round to it until 24 years later, so good for you. But it was interesting to see that it's taken this long to get to this point, and no one's looked at this area before. So what are we doing? And I'll tell you a little bit about ERP philosophy. It was someone called Kellett who was the father of it. Does anyone know, well, the non-medical people, non-surgical and non-anesthetic people, keep your hands down. Has anyone heard of enhanced recovery pathways? I'm not Charles. Has anyone heard of them? Good, a couple. Oh, all right. Mr. Cameron? Yeah. Okay. So I'm going to lead you through this philosophy. Okay, so Kellett was the Danish chap who did the original work on this. NHS Innovations grabbed this by the horn and said, we love it, great. And they have been used, and I'll show you a review of where it's been used. It's basically an evidence-based approach that aims to optimize outcome and improve patient experience. Now, we have a problem with the evidence, because in hip fracture and in dementia, we've got 1 or 2 trials. So where do you get your evidence from? So you have to think about that. And this will help you understand why we designed the project the way we did. It challenges the way care is delivered. So it's proactive rather than reactive. It's thinking smart. It's not just sticking to a guidance. It's trying to think outside the box. So the pathway will have a range of things. It hopefully won't just be a list saying, make sure their blood glucose is 4 and their statin is 3. Some of them have, I've seen that. So it is proactive. And unfortunately, sometimes they have to be careful with these ERPs, because I've seen disasters where people stuck to the ERP and ended up with the patient basically losing the wrong leg in a surgical procedure because the ERP drove it down that route, and that wasn't a reactive one. So we have to be quite careful the way it's delivered. And I think what is an ERP you have to think about when you're designing it. You don't just create a tick box and go tick, 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 there you go, that's an ERP. Otherwise we're in danger of implementing something like the NHS does, the cart pulling the horse. So it has to be sort of fairly alive in a way. It empowers patients and carers to become partners in their care. And I've heard it said that the patient, when they come in, supposing they haven't got dementia, should know that in 3 days, the consultant will visit them and say, right, you can go home. And day 2, the pump or pain relief will be racked down a bit. So it's almost like a contractor timetable of care. which can be quite bespoke, allegedly, in some countries. Not sure how it works universally, but you'll see some more issues about that in a bit. Implementation is a problem and a key issue, and it needs to be available to every patient from every nurse and by every clinical team in the system. You can't just have, oh, well, it's Friday, it's ERP day, and then Saturday, right, the weekend staff are on, let's just go back to the old system. It's just not going to work that. You'll end up with a disaster. And ward managers and senior nurses are critical. These are like the change agents. These are the innovators, the leaders who are there to use the system and work with it to try and bring their staff on. And we've got people called service implementation leads that Perfected is going to have. So the ERP evidence. Before I show you that one then. So ERP evidence. Do we think there is good evidence for enhanced recovery pathways in hospitals, not in dementia? Yes? Hands up. Come on. And no? Yeah. Should we see the slide? And then you can comment. So this is a review done by Patton in the BMJ in 2014. And there are 17 systematic reviews and 12 randomized controlled trials about enhanced recovery pathways and 10 economic evaluations. However, not a single cost analysis or study has been identified. And for some reason, most of the evidence is in colorectal surgery. So it tends to be in elective procedures. But the evidence for colorectal surgery is that it can reduce length of stay by between 0.5 and 3.5 days, which is a significant amount, okay? However, it's clear that there are also fewer, in all the trials, fewer post-operative complications. You have reduced roundabout patients and have improved patient outcomes. But one of the big problems, and I picked this up from the review, was it can become a bit like a sort of, not racial, but it excludes patients. So basically, if you're not on the ERP, we don't want to know. So it can become siloed into, you've got to have this diagnosis, this problem, and then you get that care. If you've got it, oh, well, sorry, you're not relevant to that. Now, they've noticed that in some of the literature already, in some of the trials, that hospitals, there are these sort of tribes of patients who are not falling into the ERP, and they perhaps could benefit from an ERP in their own condition. Now, that's probably because it's not been developed yet. So that's something we need to be careful about with Perfected, that we don't create a thing that only accepts patients who have specific types of dementia, for example. And we're trying to make it with presumed dementia as well. And we've also got to make sure that, in theory, patients without dementia could go through the pathway. And we do suspect in our pilot, we may well recruit people with delirium who will go through the pathway and hopefully benefit from that. And we'll work that out later because we're following people up for 6 months. So we'll be aware they'll have delirium after the horse has bolted a bit. So the key questions for our project are, can we help NHS staff deliver the care they want to and that the patients expect and deserve using the vehicle of ERP in our prototype condition, which is acute hip fracture with a form of cognitive impairment or presumed dementia? That's one of our research questions. Research question 2 is, can we create a platform, utilizable, that's the ERP, in any health system, in any patient with cognitive impairment entering acute hospital care in any country in the world? That's a bit grandiose, but we did a global survey. We've had an international survey. We did approximately 30 to 40 respondents on that from about 15 to 20 countries, including China, South America, all over the place. And so we hope through that, maybe when we develop this thing, to be able to push it back out. And in fact, America is very interested in this because they were, certainly Indianapolis, they were thinking, gosh, if you can do this, then we'll take it on and we'll trial it in our country. So it's a bit of two-way knowledge transfer internationally. No one's doing it in the world in dementia in this setting. So that's why it's a unique opportunity. So what have we found? Here we go. Here's the data. Quickly write it down, and I'm not going to tell you much, okay? We undertook a survey of every single, and it was really hard work for the team, every single English and Scottish and Welsh and Irish hospital we could get our hands on. We didn't go to Southern Ireland, and we went to Shetland. It was quite interesting. Shetland did actually respond. We didn't actually go there, but we contacted them and said, please send us all of your documentation you have on dementia. We'll take anything. And we got 600 documents. And we got responses from, I think it was 200 to 300 hospitals across the country. And it's quite interesting that there did seem to be some variability in what was out there. And in fact, most fascinating was that certain parts of this country may not have any dementia at all because they don't have any paperwork. I think Wales was quite limited, which is quite surprising. And I think Shetland did have something, but it wasn't particularly good. And Scotland was not as good as England on its policies and guidance. Now, that may be because they didn't respond through the FOI, but it is fascinating. We're still analysing that, because obviously 600 documents is a hell of a lot of stuff. I mean, some of these are about 100 pages each, so you can rack it up. It's probably going to take us another 6 months to go through all this information, so hopefully it will still be in date. But as it goes, it is being fed into the development, and it's helped us orientate on the landscape in the NHS. The second bit is ethnography, and that's what we've been doing and still are doing at the moment, which is basically looking at the working environment. And this is through observations with researchers and using patients and carers, actually going in with a clipboard for an hour or two, well, not necessarily a clipboard, but some form of notice device, and just observing what is going on. And I mean, there are some headings like the ward's too cluttered with trolleys seems to be an issue. The environment, there aren't enough places to sit down. It seems very narrow corridors, all these bloody computers and drug trolleys with computers on them. It seems to be a bit scary sometimes to some people. And what was quite interesting, there seems to be some pinch points. There seems to be a lot of stress and potential weakness where provider divide operates. Now, does anyone know what provider divide operates? Well, Charles does, because he's primary and I'm secondary. And there's a social worker in the room as well. So they just demonstrated some of the divides. Okay, so it's that we've got to get through the system. So we've got to get out of the EDs, up to the ward, hurry up, going time pressure. Now we've got to get them out because the bed, we need the bed, there's no money. So that causes, I used to fight with my orthopaedic surgeon, back in Oxford, and it's still there, isn't it? The shouts, no, they don't shout. There's stress. They spend an awful lot of time form filling and trying to get people moving. And that means less contact with the patient, doesn't it? Which is really tragic. Now, that's only a preliminary sort of finding, so, but quite powerful. Finally, we've been undertaking our systematic review, and as you can guess, it's limited, so we are using other sources of literature and we're developing that. I'm not going to tell you the findings of that because it's subject to a Cochrane review, and we are, well, I haven't actually been shown it because they knew I would present it here. So the team in charge of that are in charge of that, and it will be finished imminently in the next few months, and hopefully drive our development of this intervention. Okay, so what we will explore in the trial, before I show you what the trial is, the last slide. Does an ERP get used in practice, i.e. implemented? That supports the pattern paper which says there is very little evidence of implementation in ERPs. So we need to get into that, and this could be a really useful output beyond dementia. So you can actually do it, forget the illness. We've actually looked at this in detail, in the most detail anyone ever has, certainly in the NHS and maybe in the world, about the way these things actually occur. So we'll be collecting useful data on that, which is really helpful. We'll also be looking in our sort of pilot, can it enhance rehabilitation outcomes? And can it lead to meaningful outcomes across the system? And we should have put managers, I suppose, as well, but that's the cost-effective bit. But for patients, staff, and also be cost-effective. Now, it is only a pilot, so I should say, is there preliminary evidence of some cost-benefit? So I've learned I mustn't use cost-effectiveness unless it's a full efficacy trial. So we've told you the context, the why, the how, and I've talked to you about the history, my being shouted at by orthopaedic surgeons in Oxford, and now we'll show you the design. And this is perfected. And I'll just briefly run through it with a lot of text there. Where we are at the moment is approximately work package 1, as you can see, coming towards the consensus meeting in the summer. So we're doing the ethnography, and we're about to go back to ethics and some other bits in about a week or two as well. But we finished the International National Survey, finished the Freedom of Information Act, we finished some of the observation work, we finished with the emergency department, that was wonderful, but we don't need any more of that. We've got enough evidence there, so we're analysing that at the moment. We move then on, once we go from this consensus meeting into a live, we put it in the wards. So we're going to 3 hospitals, one in Yorkshire, one in Nottingham, and one in East Anglia. And we're going to say, here it is, this wonderful, glossy thing called an ERP Perfected. It's yours. We'll train you. You have a go with it, and rather like a new phone, tell us if there are any problems with it. So it's almost like the beta version of Microsoft. We're going to get them to sort of use it and try, and we'll be seeing them every few months and saying, okay, we're going to their ward rounds. Is this thing any good? Have you got any problems? Are you finding it helpful? If not, tell us why not, and then we will amend it. So it's a kind of 1 year of intensive redesign through an audit checklist process. And then we move on finally in about 2016, September, to an RCT, 10 hospitals, approximately 400 patients, cluster randomized trial with basically 6 months of follow-up. So they all get the ERP or they get control, and we follow people up at 3 months or 6 months and see what the outcome is. And then finally, we have another one of these meetings, which you're most welcome to come to. And then we'll be publishing and hopefully writing, or maybe not, because we'll have the answer, a bid for a 100 hospital, 60, in fact, do you remember? When we originally powered this up, we did some power calculations and we thought, well, based on the current data, we need 50,000 patients for this, which is an impossible trial to do. So we will have an idea whether a definitive trial can be done, whether it's needed, and what it would look like, and perhaps apply to the HTA when they've recharged their fundings, because they've got a bit of a funding issue at the moment, to give us the relevant funds to deliver a definitive, full, cost-effective in the new NHS. Thank you.